we are dealing with engineered antibodies that express a dual specificity. One of them against the B cell antigen in the case of B cell lymphomas, and most commonly CD20 is the ones that are being developed in clinic at this time, more advanced. And the other one against a component, an antigen of an immune cell, mostly T cells, and we are going to speak mostly about CD3. So when this happens, the antibody will activate the T cell by binding the CD3 in a way that is not restricted by MHC class 1, which is important for lymphomas because many of the aggressive ones do not express it. And at the same time, they bring in close proximity the B cell, the lymphoma cell, and the T cell, and this will promote the formation of an immune synapse and the cytotoxicity from the T cell against the B cell. Many cytokines can be produced and will also help in the amplification of the immune response and recruitment of more T cells. So this will be the main mechanism. What we are doing is we are harnessing our own, the patient's immune system to destroy the lymphoma cells. And this is in a general way, the mechanism of action. Yeah, I think what we have news pretty much every meeting. So during my presentation, I tried to focus on diffuse large B-cell lymphoma or large B-cell lymphoma, the aggressive subtype, and follicular lymphoma as the indolent subtype. Of course, there's some results in other types of lymphomas, including mantle cell lymphoma, but it's difficult to cover everything. And I would say that regarding B-cell lymphoma, we have now in Europe and US 2 products approved, glofitamab, which is administered IV for a limited duration, 12 months, 12 cycles, it's about a bit longer than 8 months, and epcoritamab, which is administered subcutaneously until progression. And both trials and the trials that led to approval are phase 2 trials, non-comparative, and they included a similar number of patients, and at this time they have a quite similar follow-up between 18 and 20 months at the last presentations at Lugano meeting last year and ASH meeting. So what we see is that we have a overall response rate that is 50 to 60%, and we have a complete response, which is about 40% for both agents. And both translate in very durable responses if they are complete responses. Meaning, if you look at glofitamab results, about two-thirds of the patients that are in complete response maintain this complete response at 18 months follow-up. If you look at epcoritamab with 20 months median follow-up, you have a 21 months duration of complete response median. And these trials are still ongoing, so we'll probably see more developments. And we are also already seeing a lot of developments in terms of combinations of these monoclonals with chemotherapy, with other immunotherapies, with antibody drug conjugates. But these results are still a bit preliminary and a bit exploratory. But for the time being, this got us the approval of these 2 antibodies for the aggressive subtypes. And we got mosunetuzumab approved for the follicular lymphoma. Mosunetuzumab is less effective in the aggressive subtypes, but it achieves a very good response rate and complete response, also around 60% complete responses in follicular lymphoma. And this is quite durable. And we have to take into account that follicular lymphoma is very heterogeneous, and we have many options besides chemotherapy. But after a while, when you are at 3rd line or after 2nd line, you really are in trouble because you don't have a standardized choice. And many patients get resistant to chemotherapy, and they need an alternative mechanism of action. So bispecifics come here as an attractive option. We are not sure, neither in diffuse large B cell, neither in follicular lymphoma, we are not sure they will be curative. We have not seen yet a plateau, but we believe that with further follow-up, we might still understand better the curative potential of these drugs. Also, they have some advantages because we tend to compare the results with the results of CAR T cells. The mechanism of action is not that different. The complexity of the treatment with bispecifics is much lower because we have it as an off-the-shelf medication. We don't need to do lymphodepletion. We don't need to wait for manufacturing. And so we can, for some patients that cannot really wait this time, this might be a more attractive option. Maybe in the future, when we learn more about treatment of with CAR Ts after bispecifics, they might even be used in the future as a bridge. But the truth is, we are not sure this will be possible. For the time being, we prefer to do the opposite, to use first CAR Ts in the patients who are candidates and have access, because it's not uniform in everywhere, the access to CAR Ts. But if we can, if the patient is a candidate, if we don't anticipate too much toxicity, we prefer to use the CAR Ts first and then to salvage the patient if it doesn't work with bispecifics. We already have also interesting trials using bispecifics as maintenance after CAR Ts, which is also interesting in aggressive lymphomas. You know, as in all treatments, we need to get trained. We physicians need to learn and need to get trained in these treatments. I would say it's quite easy for a center that uses to administer CAR T cells. It's not difficult at all because the toxicities are similar but in a much lower range. So we see cytokine releasing syndrome, and we need to know how to treat cytokine releasing syndrome because this can become serious if we don't treat it in the beginning. We have some mitigation strategies, but they might not be entirely effective. So we need to know how to deal with this. Sometimes we need to admit patients, although we do our best to do most of the treatment as outpatients because this is a prolonged treatment. So we really prefer to develop strategies of training the patients, the physicians, the caregivers to be able to administer as much as possible as outpatients. Since not all these treatments are available everywhere, people are thinking about strategies on like smaller centers who are not trained might get into an arrangement with the bigger centers, and the patients receive like the first two cycles in a more developed center who is more trained in toxicities, and then the patient can go back to his hospital. That would be, I think, a very good idea in the beginning, because at the end everybody will learn how to deal with this. It's not that bad. What I don't know yet is how are we going to deal with delayed toxicities. And I would say that the immune suppression that we are inducing, not only with bispecifics, with all the treatments that we are giving to our patients, they really open an important problem here, or they amplify an important problem because we already have this problem, is the infectious problem. So we need to be aware of the infectious risk in these patients, and probably in the future to develop better prevention strategies and treatment strategies. But for the time being, at least to be very much aware of the risk of infections and have suspect the infections early, be aware of them. Yeah.
Yeah. So,
Of course,
oh,
these are not the only toxicities we have with bispecifics, but I was just putting the focus in the things that I probably think concern most of us most, but we have other ones. We have a small range of patients who have neurotoxicities, not very impressive in terms of numbers or severity. We have cytopenias. It's true, we can deal with them with growth factors. We have hypogammaglobulinemia that we know how to deal with also with infusion of immunoglobulins. We have sometimes tumor lysis, infusion reactions, but yeah, we know the most
Yeah.
important are the first ones. Yeah. Yeah, this has been, there are groups of investigators thinking about that. The first thing
Mm-hmm.
we need to know is the mechanism of resistance, because if we are using an anti-CD3, CD20 antibody and we get a patient who loses CD20 in his tumor cells, we cannot use this type of antibodies, but there are other bispecific antibodies in development against different targets in B cells. There are also combinations with other bispecifics that act, act specifically as immune stimulators. Maybe if we get even more efficient using bispecifics in combination with other agents, either chemo or even more interestingly, immunostimulators, we might be able to cure patients earlier and to reduce the probability of developing resistance. Also, I believe that it is important to have a treatment during a limited period of time, because uh, if we are effective, we can stop treatment. And in some of these trials, patients are allowed to resume treatment if they relapse or progress, and that can also be a strategy. I mean, if we don't develop serious resistant mechanisms, we might be able to use the same agent or similar one more than once.